Hi, welcome to my presentation of the heart. So the heart is one of the major parts of the cardiovascular system. Just to review, the cardiovascular system includes the heart and the blood vessels. Those are the organs, and it also has a tissue, which is blood. The functions of the heart are basically to pump blood. That's the main function, but it also functions in maintaining blood pressure. It regulates the blood pressure by releasing hormones, AMP and BNP, which you might remember from AMP1. And it also controls the blood pressure by regulating the heart rate. So if heart rate goes up, blood pressure will go up. And if the heart releases these hormones, AMP and BNP, then blood pressure will go down because these hormones cause water secretion from the kidneys, among other things. So first we'll go over the anatomy of the heart. The heart is found in the pericardial cavity, which is inside the mediastinum. It's tilted to the left. So the main body of the heart is just a little bit to the left of the midline of the body. So it's not quite in the center, it's like center left. You have the base of the heart and the apex of the heart. The apex is actually at the bottom, or it's the inferior part of the heart, where the heart comes to a point. And then the base is actually at the superior end of the heart, where all the blood vessels emerge. So the base is defined as being the wider part of the heart, and the apex is the narrower or pointed part of the heart. The heart has 4 chambers, has 2 sides and 4 chambers. The 2 types of chambers are the atria and the ventricles. So you have on the right side of the heart a right ventricle and a right atrium and a right ventricle. And on the left side of the heart you have a left atrium and a left ventricle. Blood always enters the heart into the atria, and it always leaves from the ventricles. You have divisions between the atria and the ventricles on the surface of the heart. So you have the atrioventricular sulci that run between the atria and the ventricles. They're just basically a valley or a depression running between the atria and ventricles. So you can tell them apart, and you would also have blood vessels running in there generally. Then you also have the interventricular sulci, which run along the edge of the heart from the base to the apex. And those, you have one on each side. Those are like valleys that are separating the ventricles from each other. Then you also have the auricles. Each atrium has an auricle. The auricle is like a fleshy sort of sac on the outside of the heart that can expand with blood. So the atria have very little volume inside of them, and much of the volume is actually occupied by these auricles, which can expand as they fill with blood. The heart also has great vessels emerging from it and going into it, which are divided into veins and arteries. All veins deliver blood to the heart or carry blood towards the heart, and all arteries carry blood away from the heart or take blood from the heart. So the 2 great veins that go into the heart are the vena cava and the pulmonary veins. The vena cava is divided into the inferior vena cava and the superior vena cava. It's returning blood from the body to the heart onto the right side of the heart. The left and right pulmonary veins are going to the heart from the lungs. They're actually shown in red because the blood they carry is oxygenated since it's coming to the heart from the lungs. So you have 2 on each side. So the pulmonary veins are actually split into 4 different vessels, 2 on the left and 2 on the right. And from the front end of the heart, or in a front view of the heart, you can also see them on the back. Then the great arteries that enter the heart, emerge from the heart, are the aorta and the pulmonary trunk. The aorta comes out from the left side of the heart and delivers blood to the whole body. It's divided into the ascending aorta and the aortic arch where it curves. Then you have the pulmonary trunk, which emerges from the right side of the heart and carries blood to the lungs. So as soon as the pulmonary trunk emerges, or very soon after it emerges, it splits into the left and right pulmonary arteries. So just remember that the left and right pulmonary arteries do not actually enter the heart. They merge to form the pulmonary trunk, and then that goes into the heart. So the pulmonary trunk is different from the left and right pulmonary arteries. And on a back view of the heart, the pulmonary arteries are seen right here, and they would merge around in the middle to form the pulmonary trunk. The heart is considered a double pump because it is pumping blood to and from the lungs and to and from the body at the same time, but the blood in each of those circuits doesn't mix. So you have a pulmonary circuit and a systemic circuit that the heart is pumping blood through. The right side of the heart is associated with the pulmonary circuit. So on the right side of the heart, you have blood entering the heart from the body into the right atrium. It goes into the right ventricle. It leaves into the pulmonary arteries. Well, first the pulmonary trunk, then that splits to the left and right pulmonary arteries. Then the blood is going to travel into the lungs, through the capillary beds in the lungs. It picks up the oxygen there. It leaves the lungs as oxygenated blood, and that enters the heart on the left side. So that's the pulmonary circuit. Then the left side is associated with the systemic circuit. So you have blood entering the left side of the heart, entering the left atrium from the lungs. Then it goes to the left ventricle, and the left ventricle is going to send it out along the aorta. Just on this side, I guess it's highlighted. So the left ventricle is going to send the blood out on the aorta to the whole body, and it will return to the heart in the superior and inferior vena cava into the right side of the heart. So blood that's on the left side of the heart is always oxygenated because it's going out to the body from the lungs. Blood that is on the right side of the heart is always deoxygenated because it's coming back from the body and it's going to go to the lungs. You can always tell the difference between the left and right side of the heart because if the heart is cut open, because the left side has thicker walls. The ventricle specifically has a thicker wall on the left side than the right. That's because it needs to generate more force on the left side to get the blood to go to the whole body rather than just to the lungs. And another thing to bear in mind is that the carbon dioxide levels in the blood are always, or should always be, the opposite of the oxygen levels of the blood. So if you have oxygenated blood coming from the lungs, that blood would have very little carbon dioxide in it because all the carbon dioxide had been dropped off at the lungs into the air. And if you have deoxygenated blood that would be going back to the heart and then to the lungs, that's going to have very high CO2 levels because it has picked up carbon dioxide from the tissues as they are metabolizing and producing CO2 as a waste product, and it has not been dropped off at the lungs yet. The heart wall gets a little bit complicated. You have three basic layers of the heart wall: the pericardium, myocardium, and endocardium. But then the sublayers, especially of the pericardium, are a little bit complex. The pericardium is the outermost or superficialmost layer of the heart wall. It attaches the heart to structures around it, and it reduces friction because it actually includes a serous membrane. So the pericardial serous membrane is part of the pericardium of the heart. So you can divide the pericardium into the fibrous pericardium and into the serous pericardium. The fibrous pericardium is the superficialmost part that actually is attached to other structures in the chest cavity or in the mediastinum. Then the serous pericardium is the serous membrane, and that has a parietal pericardium and a visceral pericardium, as all serous membranes have a parietal and a visceral side. Then between those two sides, you have the pericardial cavity that contains a serous fluid. So the purpose of that serous pericardium with the pericardial cavity full of serous fluid is to reduce friction, so that as the heart is pumping and beating, it's not rubbing against the walls of the chest, which would cause damage to the heart and to surrounding structures. So it's really important to have the friction of the heart's beating reduced or minimized so that the heart is not rubbing against other structures in the chest. Also considered as part of the pericardium, and specifically part of the visceral pericardium, is the epicardium, which is fatty tissue. Well, it's loose connective tissue, but it's very fatty. And that is sort of the outermost part of the heart wall that's actually on the heart itself, and is where most of the coronary vessels that serve the heart run. So in this image here, much of this is the pericardium. This dense gray thing here is the fibrous pericardium. Underneath it you have the serous pericardium, the parietal pericardium, the visceral pericardium, and then the pericardial cavity in between them. And beneath that, if you zoom in closely, you can see the epicardium. So here in blue, this tiny little blue layer would be the visceral pericardium, and then just underneath that you have the epicardium, which you can see is full of fatty cells and contains the coronary vessels. And this is part of the pericardium, frequently considered part of the visceral pericardium, even though it's not technically a part of the serous membrane. It is right next to the serous membrane. Then inside of the pericardium you have the myocardium, which is the thickest part of the heart wall, and it's made out of cardiac muscle, so it's used for contraction. The main cell type in the myocardium is the cardiomyocyte, which is a heart muscle cell basically. You also have something called the fibrous skeleton within the myocardium, which is basically like collagen fibers running throughout the myocardium, and especially enriched in certain places where the structure needs a little bit more support, such as where heart valves are attaching. Then within that you have the endocardium, which is extremely thin. There's two layers in the endocardium. You have the subendothelium and the endothelium. So this here is the endocardium. It's much thinner than the myocardium, as you see. Much of this is subendothelium, which would be elastic and then loose connective tissue. And then the innermost layer is the actual endothelium, which is the simple squamous cells. That is continuous with the endothelium that lines all of the blood vessels also. Next we'll talk about cardiomyocytes, which are pretty specialized cells. Their structure is different from regular skeletal muscle cells. They're much shorter than skeletal muscle cells, and they also branch, and they're connected to each other with these structures called intercalated discs. At the intercalated discs you have desmosomes and gap junctions connecting two cardiomyocytes together. Desmosomes are providing strength, and gap junctions are allowing the cells to communicate. So right here you have an intercalated disc between two cardiac muscle cells, and if you zoomed in on that, it might look something like this. These are the contractile proteins used to actually contract the heart muscle. This is a desmosome linking the two cells at the intercalated disc, and then you also have these little pores, which are the gap junctions, so that ions can flow freely between these two cells, and that means that action potentials in one cell will spread to the next cell. So muscle cells contain contractile proteins that are arranged into myofibrils in order to contract, and heart cells do as well. So they also have myofibrils with myofilaments. They have the same myofilaments in them. It has the same arrangement as with skeletal muscle cells, and the contraction is basically occurring in a similar way. One of the differences is that your myofibrils in the cardiomyocytes can curve. They are not just straight. So whenever the cell branches, the myofibrils will curve to follow the branches. And they can also continue after an intercalated disc, which means that this myofibril in one cardiomyocyte also is going to link up with this myofibril in the next cardiomyocyte. So you have a single kind of line of contraction running across the intercalated disc. Cardiac myocytes also have the sarcoplasmic reticulum and the T-tubules, just like skeletal muscle cells do. Some differences are that they have more myoglobin well, some other differences, some internal differences, are that they have more myoglobin than skeletal muscle cells, and they have more mitochondria than skeletal muscle cells. Myoglobin, as you may remember, is a protein similar to hemoglobin that binds oxygen in muscle, and it basically acts as like an oxygen reserve, just a little oxygen storage depot. And then mitochondria, of course, make ATP. So heart muscle cells have more myoglobin and more mitochondria so that they can use oxygen more efficiently to make ATP, so they can make more ATP because they have a lot of need for ATP, and it's very important that they never run out of ATP because then your heart would stop beating. So you also have specialized cardiomyocytes that are part of the conduction system of the heart. You can call them pacemakers. Especially the ones that are found in the sinoatrial node, which is right here. So this is a diagram of the conduction system of the heart. This would be all embedded within the myocardium, and all of these cells that are part of this would be specialized cardiomyocytes. The ones in the SA node up here are responsible, or primarily responsible, for setting the heart rate for the whole heart. So they are special cells because they can depolarize spontaneously in a repeating rhythm that's about 100x or 100 times per minute. So they'll generate about 100 action potentials per minute. And then those action potentials will spread along the rest of the conduction system to the regular cardiomyocytes that actually do the contracting. So this system is making sure that the heart contracts all at once in a coordinated fashion. The rest of the cardiomyocytes in the conducting system of the heart do have some ability to depolarize on their own, but they're mostly carrying action potentials just to the rest of the conduction system and ultimately to the regular cardiomyocytes. The heart also has valves inside of it to prevent blood from flowing backwards through the heart. You have two types of valves, semilunar valves and atrioventricular valves. The semilunar valves are always located between a ventricle and a great artery, and the atrioventricular valves are always located between an atrium and the ventricle. So you have one of each type on each side of the heart. On the right side of the heart, you have the pulmonary semilunar valve, which is separating the right ventricle from the pulmonary trunk. You also have the right atrioventricular valve, which is also called the tricuspid valve because it has three cusps, separating the right atrium from the right ventricle. Then on the left side of the heart, you have the aortic semilunar valve, separating the left ventricle from the aorta, coming out here. And then between the left atrium and the left ventricle, you have the left atrioventricular valve, also called the bicuspid valve because it has two cusps, or the mitral valve. Those valves are formed by the fibrous skeleton, which was part of the myocardium, and they're also coated by endocardium. So the strength of the structure of the heart valve is coming from the fibrous skeleton, which is part of the myocardium, and then is lined with endocardium on top of that. Every valve has a ring going around the opening that is going to close, and it has some cusps, 2 to 3 cusps. Actually, generally 3 cusps, but the mitral valve has 2 cusps instead. Anytime the blood is pressing on the cusps so that it's kind of filling them up, it's going to push the valve closed. If the blood is pushing on the valve from the opposite direction, then it's going to push the valve open. So if you had blood on this side of the valve pushing into it, it would be filling those cusps up with blood, and that's going to push this valve closed. This valve is oriented in the opposite direction, so if you had blood on this side pushing onto that valve, it's going to be pushing the cusps open. It's going to get into that little crack between them and push them open. Your atrioventricular valves also have structures called chordae tendineae that attach to them and run down into the ventricle and attach to papillary muscles on the walls of the ventricle. So those muscles and the chordae tendineae are designed to prevent the valve from opening the opposite direction. The AV valves can be under quite a lot of pressure, and they need maybe some help to prevent them from opening the wrong way under pressure. So whenever the valve closes, the papillary muscles will contract, and the chordae tendineae will then come taut, and the valve will be held closed. So looking more at the atria, they have auricles. Each atrium has one auricle, which, as I mentioned, is a flap that can expand to accommodate blood or to hold extra blood. Those are visible on the external surface of the heart, here and here, as little flaps. In the right atrium, if you cut it open, inside of it you can see pectinate muscles running across the inner wall. Those muscles are part of the myocardium. Then you have the intraatrial septum running between the atria. It's just the wall between the two atria. It's very small, the atria are very small, so a lot of the time it's hard to see that wall if you actually dissect the heart. It's very short, it's very brief. When you are a fetus, then you have a little hole in the intraatrial septum called the foramen ovale, and it allows blood to pass through between the two atria. So that's because the fetus doesn't have any need to be breathing. It's not oxygenating its blood in the lungs. Its blood is being oxygenated in the placenta. So you actually don't need to run blood through the heart the regular way, and blood will just go straight from one atrium to the next and then back out of the heart again, bypassing the lungs. The tissue in the lungs is very delicate, especially when it's developing. So you want to avoid having high blood pressures running through the lungs that could damage that tissue as it's developing. So, and there's not a need for it. So that's the reason why blood bypasses the lungs in the fetus. Then once you are born, that little hole is going to close up, and what you are left with is the fossa ovalis, which is a small depression in the intraatrial septum where the foramen ovale used to be. And so this here is the fossa ovalis in an adult heart. Usually it doesn't look quite as clear as that. It's usually pretty hard to see, actually. Then we'll go into a little more detail with the ventricles. As I had mentioned, the left ventricle has thicker walls than the right ventricle. It's also larger overall, so it can hold a greater volume of blood, which makes sense because it's passing blood to the whole body, not just to the lungs. The ventricles have little ridges lining the interior of them called trabeculae carneae, which are really kind of, I guess, tortuous and twisty and bendy. Those are part of the myocardium, and the trabeculae carneae will have kind of larger muscles emerging from them, which are the papillary muscles that connect to chordae tendineae. So all these little, they look like little fingers actually coming out, but they would actually be ridges just twisting along the surface of the ventricle. These are all the trabeculae carneae. And then some of them get really large, and those are the papillary muscles. And out of each papillary muscle, you have the chordae tendineae emerging and connecting to the flaps of one of the AV valves. So then when the ventricle is full of blood, the AV valve is going to be pushed closed. But it can also be pushed like back open the other way. It can be blown back out into the atrium because there's so much pressure inside the ventricles when they're full of blood that it would actually be enough to blow the valve back out into the atrium and open it the reverse direction. So the papillary muscles and the chordae tendineae are designed to prevent that from happening. When blood pushes this valve closed, the papillary muscles contract, the chordae tendineae become taut, and the valve is kind of held flat and straight and prevented from blowing back into the atrium. Then between the ventricles, you have the interventricular septum. That is the part of the septum that's easy to see in dissection because it's very large, and it is right here. It's just the wall of the myocardium between the two ventricles. And up here you would have the intraatrial septum as well, but you can't see it in this diagram and that's pretty normal. So we'll just review some of the heart anatomy that we've learned so far. So here you have the base of the heart, and at the bottom is where you have the apex of the heart. You can see the auricles on the external surface of the heart. This is the the left auricle. This is the right auricle. Then you have the great vessels entering and emerging from the heart. This is the inferior vena cava. Here's the superior vena cava. So blood would be coming in here to the right atrium, then into the right ventricle. It would have to pass through the right AV valve or the tricuspid valve. Then it's going to go out along the pulmonary trunk and then into the right and left pulmonary arteries. In order to get there, it has to pass through the pulmonary semilunar valve. Then blood would go to the lungs and come back to the heart in the left and right pulmonary veins, these being the right pulmonary veins, and these are the left pulmonary veins. Those enter the heart in the left atrium, right here. Blood would then travel into the left ventricle, going through the bicuspid valve or the mitral valve. Blood is then going to exit into the aorta, traveling through the aortic semilunar valve to get there. First going into the ascending aorta, then into the aortic arch, and then on to the rest of the body. Then some more features we have inside the heart are the intraventricular septum. There's another intraatrial septum that's hidden by the great vessels here. This little depression is the fossa ovalis that's left behind from the foramen ovale. You can barely see here. This is, I guess this little shadow is a pectinate muscle in the right atrium. Then in the ventricles, you have the trabeculae carnae, you have the papillary muscles, and the chordae tendineae running from the papillary muscles to the cusps of the AV valves. And those are the main points of the heart anatomy. Oh, actually the heart wall as well. The endocardium is visible here as this thin line. Then you have the myocardium, which is the thick part of the heart wall. And then external to that, you would have the pericardium, starting with the epicardium, then the visceral pericardium, the pericardial cavity, the parietal pericardium, and then finally the fibrous pericardium. All of that would be not shown in this diagram. It's external, except for the epicardium actually, which would be these fatty bits. So we'll go over blood flow through the heart again. Just make sure that you know this pretty well, like the pulmonary versus systemic circuit and what structures blood passes through on its way through the circuits. So starting with the right side of the heart, that's associated with the pulmonary circuit. So blood is going to be coming into the heart from the body in the vena cava, goes into the right atrium, passes through the tricuspid valve into the right ventricle, passes through the pulmonary semilunar valve into the pulmonary trunk, passes into the right and left pulmonary arteries. Then it would travel on to the lungs in the systemic circuit and return to the heart. It will return to the heart into the left atrium through the pulmonary veins, the left and right pulmonary veins. Then from the left atrium, it'll travel into the left ventricle, passing through the bicuspid or the mitral valve. From there, it will pass through the aortic semilunar valve into the aorta, and then onto the rest of the body and the vessels in the systemic circuit. In addition to the pulmonary and systemic circulation, you also have the coronary circulation, which is basically part of the systemic circulation actually, but that is the blood flow to the heart itself. So the coronary circulation includes the coronary veins and the coronary arteries. Coronary arteries would be delivering blood to the heart wall. Then the coronary veins are draining that blood and returning it to the heart chambers. So there's a lot of individual variation in the specific veins and arteries that make up the coronary circulation, where they run, which ones you have. It can vary a lot from person to person. And you also have a lot of anastomoses in the coronary circulation. Those are extra vessels between vessels, basically, that allow blood to skip some parts of the circulation by going directly into another part. So anastomoses can let blood skip part of the circulation. They can let parts of the circulation that normally would not connect to each other. And those parts can be kind of distant from each other at times, depending on how long the anastomosis is. So this is important in the heart because you don't want any part of the heart wall to ever be without blood supply. If you get a clot in one of the coronary veins or arteries, then it's important that blood has another path that it can follow to reach that part of the heart wall, so that you don't have heart tissue dying due to lack of oxygen. So the collateral circulation in the heart is the anastomoses that exist that connect different parts of the circulation in different ways. And it's also refers to the ability of the heart to form new anastomoses in response to problems with blood flow. So if you have a specific part of the heart that isn't getting enough blood, the heart can actually form additional anastomoses connecting different parts of the circulation to skip wherever the blockage is, so that part of the heart wall can get blood again. So these are the largest, most common coronary arteries. They are all coming out of the aorta, right at the base of the aorta. It's actually hard to see where they emerge from the aorta because they're so right in the base of it. You have the right and the left coronary arteries. The left coronary artery comes out right here. The right coronary artery comes out right here and travels along the right side of the heart. Coming off of the right coronary artery, you have a couple of major branches. You have the marginal artery that comes down along the side of the heart. And then in the back of the heart, you also have, here's the right coronary artery continuing around the back. You have the posterior interventricular artery coming off of it at the bottom. Then for the left coronary artery, that's a shorter artery. It only travels like basically from the aorta to the base of the left atrium. And then it's going to split. It forms the anterior interventricular artery, traveling down to the apex of the heart. And it forms a circumflex artery that continues around to the back of the heart. You also have one main coronary vein that is very common, the coronary sinus, and it usually has 3 other large veins draining into it and merging with it. Altogether, this is going to drain into the right atrium through the coronary sinus right by the inferior vena cava. So the coronary sinus can be seen on the back side of the heart, and it would actually travel around to the front side as well. It's just harder to see on the front side. Then the 3 veins that merge to form the coronary sinus are the great cardiac vein right here that travels around to merge into the coronary sinus here. Then you also have the middle cardiac vein, which is right here. And on the front side of the heart, you have the small cardiac vein, which is here. All of those merging into the coronary sinus, which ultimately drains into the right atrium by the inferior vena cava. There's a couple of common conditions that involve the coronary circulation. Of course, heart disease, cardiovascular disease is the #1 cause of death in the United States, and these conditions would be contributing to that. So first you have coronary artery disease, or CAD. That involves plaques forming in the coronary arteries, which block blood flow. This is called a silent killer because while the disease is developing, you will not know that you have it probably, unless there's some reason why you would get the scan done to have that checked. But you generally aren't going to have any symptoms at all until the disease is well progressed. So you start with just a very small plaque in one of your coronary arteries, and that's going to grow gradually, and it takes years for it to grow, but eventually it can become a pretty large plaque. So when it's small like this, it's not blocking blood flow, and there's no way for you to know that it exists. Only when it gets big enough to start blocking blood flow do you have the chance to realize that it's there. So once the plaque is large enough to block blood flow, it's not going to be completely blocking blood flow yet. It's going to be just reducing the amount of blood flow that can go through this artery. And that's going to mean that you have at times not enough blood supply to the heart, or not enough oxygen supply to the heart, which is myocardial ischemia. And then that can cause angina pectoris. So anytime the heart or the myocardium is not being sufficiently supplied with blood, that means that it's not being sufficiently supplied with oxygen, and that means that you have myocardial ischemia. And in general, when you have myocardial ischemia, you're going to feel that as chest pain, which is called angina pectoris. So you would generally have that only when there's not enough oxygen for the myocardium. If you have a partial block from a plaque, then you might be getting enough oxygen, and you might not have the ischemia or the angina pectoris. But then when you start exercising, the oxygen demand of the heart goes up, and then you may not be able to have enough blood flow, and then you would get angina pectoris. So having heart pain or chest pain when you are exercising, or any time that the heart's demand goes up, which would include like any time that your heart rate has gone up, the heart's oxygen demand will have gone up too. So anytime you have the heart's demand go up and then you get chest pain as a result of that, that should signal that you may be having angina pectoris, and you should probably talk to a doctor. As the disease continues to progress, you eventually can get complete blockage of the artery. So you can have part of that being the plaque, the initial plaque, and part of it being a blood clot, because as you get less and less space available in the artery, you can get some kind of sluggish moving blood in there, and that is predisposed to forming clots. So at that point, that artery is completely blocked off and no blood can get through. It's possible, if that formed in a gradual process, that the heart could form a collateral circulation, an anastomosis to go around the blocked area. But if this clot forms suddenly or arrives suddenly from another part of the body, then you're going to have a sudden blockage of sudden complete blockage of blood flow, and that will cause a myocardial infarction or a heart attack. Myocardial infarction is abbreviated MI. So anytime you have a sudden complete blockage of the artery, of a coronary artery, that is a myocardial infarction. Usually that would be caused by a blood clot, but it's possible that something else could cause it too. It's frequently a complication of CAD because in general, once you have this advanced plaque in your artery, it's easier for a clot to block it off the rest of the way. Anytime you have that happen, whatever heart tissue is not being supplied with oxygen is going to start dying. So you'll have part of the myocardium that was supplied by that artery basically die off. And when you heal, it will be replaced with scar tissue, which is strong tissue, but it does not contract. So that means that your heart will be permanently weakened following a heart attack. So sometimes you have a quote-unquote minor heart attack where not very much of the myocardium dies. That would be maybe okay. But of course, sometimes you can have a lot of the myocardium die, which is not okay. The symptoms for a heart attack are not necessarily what you would expect. Of course, you can have chest pain. You could also have a sensation of like crushing pressure in the chest, but you don't have to have chest pain or pressure in the chest. It's not always a symptom of a heart attack, strangely. Sometimes that pain that's coming from your heart, you could actually feel like it's coming from another part of your body. It could come from your back, your arm or your arms, your neck, your abdomen. Those would be the common places. You could also have nausea, you could have shortness of breath, just the feeling that you can't get enough air, basically, and you can have anxiety or, the sensation of impending doom. So you could have all those things or any combination of them. You could have them with or without chest pain. If you're having symptoms of a heart attack that do not include chest pain or chest pressure or anything with the chest, that's called a silent heart attack or a silent MI. You are having symptoms, but they aren't the symptoms that would make you naturally think that something is wrong with your heart. Right? If you just have arm pain, then you're not necessarily and you feel kind of anxious, you're not necessarily going to think, oh, something's wrong with my heart. If you have chest pain, you will think that maybe. So it's important to know that women are less likely to have chest pain or chest pressure with a heart attack, and they're more likely to have a silent myocardial infarction. So it's important, especially as you're aging, to be aware of the symptoms of a heart attack, and then it doesn't have to involve chest pain, chest pressure. Like for women, it can be common to have just like nausea and anxiety. That could be a sign that you're having a heart attack, especially if you're older. So it's important to know those symptoms so that you can, call a doctor, call 911. If you're having a heart attack, definitely 911 is the one. That's the one you need. Okay, so now we'll talk more in detail about the conduction system of the heart. So we'll go over the anatomy of the conduction system in more detail. We already mentioned the sinoatrial node, or the SA node, which is located in the right atrium. So that is the main pacemaker for the heart. The cells there discharge or fire action potentials rhythmically about 100 times a minute. You have axons from the sympathetic and parasympathetic nervous system coming into the SA node to contact it to moderate the heart rate, either speeding it up or slowing it down. Rhythms generated by the SA node are called sinus rhythms. So if you've ever heard the term sinus rhythms, that just means heart rhythms that are determined by the SA node. Coming out from the SA node, you have the atrial conducting fibers that travel down the walls of the right atrium to the next node. Part of the atrial conducting fibers includes the Bachmann's bundle, which goes across to the left atrium and distributes the impulses from the SA node to the left atrium. Then the atrial conducting fibers that converge on the next node here are leading to the AV node, the atrioventricular node. The atrioventricular node gates basically separates the ventricles from the atria, separates the conduction system for the ventricles from the conduction system for the atria. So you'll have action potentials generated in the SA node that travel basically throughout both atria almost simultaneously. I mean, it does take a tiny bit of time for the action potentials to travel, but they are very fast, so almost instantaneously. Then when those action potentials reach the AV node is going to delay their propagation for a little bit. So a tiny bit of time passes, and then the action potentials continue on to the rest of the conduction system that carries them to the ventricles. That way you can make sure that the atria contract first and the ventricles contract second, which is really important for the heart to function correctly, as we're going to see when we go over the cardiac cycle. The AV node also has an ability to generate action potentials on its own, not just conducting them between different parts of the system. It can make them itself, which means that if you have damage to the SA node, then the AV node can take over the function from the SA node. So next, the action potentials are going to enter the Purkinje fiber system, which is going to distribute them across all of the tissue of the ventricles. So first you have the AV bundle, also known as the bundle of His, leading out from the AV node and entering the interventricular septum. Pretty high up in the interventricular system, the AV bundle is going to branch to form the right and the left bundle branches, and those continue traveling down the intraventricular septum until they reach the apex of the heart. At that point, they are going to, the conduction system is going to move back up the walls of the ventricles, and this part, or these fibers here, are called the terminal branches. They're also sometimes called just the Purkinje fibers. So Purkinje fibers means these cardiomyocytes in the heart conduction system that travel in the walls of the ventricle from the apex up to the top of the ventricles. Purkinje fiber system refers to all of the cardiomyocytes in the conduction system that are distributing action potentials to the ventricles. Another thing I'll mention about the conduction system is that you can't really see it in actual dissected heart specimens very well. Occasionally you might be able to see one of the nodes. It's like a tiny bit paler than the rest of the tissue, but by and large, the conduction system is invisible to the eye. The conduction system is made of pacemaker cells, which are modified cardiomyocytes. Most cells that can fire action potentials have a resting membrane potential, but pacemaker cells do not, because they are continually generating action potentials, so they're always in some part of an action potential. They're in one phase or another of an action potential at all times. They are never at rest, so they don't have a resting membrane potential. Their lowest membrane potential in the heart is about -60 millivolts, and their highest membrane potential is about 10 millivolts. There's a special type of channel that these pacemaker cells use in order to generate these rhythmic action potentials spontaneously, which is called the hyperpolarization activated cyclic nucleotide gated ion channel, which is luckily abbreviated to HCN. So the hyperpolarization activated cyclic nucleotide gated ion channel, that's just telling you what is going to open the channel. So most ion channels are gated by one thing, maybe voltage, maybe some type of chemical that has to bind it as a ligand. But the HCN channels are gated by two things, both voltage and a ligand. So they are going to be opened anytime the cell is hyperpolarized. That's the hyperpolarization activated. And they're also activated by their ligand, which is CAMP, or cyclic AMP. Cyclic AMP is a cyclic nucleotide, basically a nucleotide that has been formed into a circle. So that's why they're called hyperpolarization activated cyclic nucleotide gated ion channels. So this is a diagram of the HCN channel. It can be activated by voltage. So here it is in the closed state, which it would be at most voltages. Then if the cell hyperpolarizes, it will open. It can also be opened or closed by CAMP. So if you do not have CAMP bound to the channel, then it will be closed. And if CAMP does bind to the channel, then it will open. And I should mention that actually CAMP is not called CAMP. I just call it that because it's easy to say, but the proper name for CAMP is cyclic AMP. Even in abbreviated format, we write it CAMP, but we say it's cyclic AMP, unless you me, in which case you call it CAMP. Something else that's special about the HCN channel is that it is not selective. It's a non-selective cation channel, which means that any ion that has a positive charge can travel through the HCN channel. Most of the ones that we had talked about in ANP1 were selective for one cation or one anion or another, so they would only let one ion pass, but HCN channels will let anything with a positive charge go through. You find HCN channels in the pacemaker cells in the heart. The other place where you find them in the body would be in the brain. There are certain parts of the brain where it's important to generate these spontaneous rhythmic action potentials, and those cells also have HCN channels to let them do that. Action potentials in pacemaker cells are different, a lot different from the action potentials that we're used to from the brain and from skeletal muscle. So they have 4 phases, which are slow depolarization, full depolarization, repolarization, and minimum potential. And they involve 3 different types of ion channels. So you have your HCN channels that we just talked about. You also have voltage-gated calcium channels and voltage-gated potassium channels that contribute. So you start off, we'll start with the cell at the minimum potential, which is about -60 millivolts. At that point, you enter the slow depolarization phase, and the HCN channels open due to the low membrane potential. So when the HCN channels open, since they are non-selective cation channels, you have sodium and potassium both crossing the membrane through those channels, but sodium is going to cross faster than potassium does. So remember that sodium is highly concentrated inside of the cell and potassium is highly concentrated outside of the cell. So when you have an HCN channel opens that lets both of those cross, sodium is going to be flowing into the cell and the potassium will be flowing out of the cell. When sodium enters the cell, that is depolarizing, it makes the inside of the cell more positive. When potassium exits the cell, that is repolarizing or hyperpolarizing, and it makes the membrane potential more negative. Because you have positive charges leaving the cell, the inside becomes more negative since it has less positive charges. Since both of those ions are crossing, in general, you might expect for their effects to kind of cancel each other out. But actually they don't, because sodium is crossing a little bit faster than potassium. So for sodium, that is a positively charged ion, which is concentrated outside of the cell. And the inside of the cell at the beginning of this phase is negative. It's at -60 millivolts, which means that the sodium, the positively charged sodium, is going to be attracted, electrically attracted, to the negatively charged inside of the cell. So sodium is entering not only because it's flowing down its concentration gradient, but also it's because it's being attracted to the negative voltage inside the cell, which means that sodium is crossing pretty fast. For potassium, that is leaving the cell down its concentration gradient, but it has a positive charge also, and since it's concentrated inside the cell, the outside of the cell is positively charged compared to the inside. Potassium is actually already on the side that it would be electrically attracted to. So it's going to cross down its concentration gradient, but that also means that it's moving towards positive charges, which it is repelled from. So it's going to cross a little bit more slowly than sodium does. So even though you have sodium and potassium both crossing the membrane, sodium is crossing faster, potassium is crossing slower, which means that overall sodium is entering the cell and the membrane potential is going to become more positive. So here's your image for the slow depolarization phase. The only channel that's open is the HCN channel. You have these positively charged sodiums entering the cell, and you have positively charged potassiums exiting the cell, but you have more sodium entering than what you have potassium leaving, which means that overall the membrane potential creeps more positive, and it's going to creep up slowly, which is why it's called the slow depolarization phase. It's going slow because of the potassium that's leaving the cell. Then when you get at about -40 millivolts, the next phase will begin, the full depolarization phase. At -40 millivolts, the voltage-gated calcium channels will open, and calcium will enter the cell, going down its concentration gradient. When that happens, calcium is bringing 2 positive charges into the cell for every 1 calcium ion that enters, since it's calcium 2+, which means the cell is going to start depolarizing very quickly. Right, so in the full depolarization phase, the voltage-gated calcium channel is the channel that is open. You have calcium entering the cell, and the membrane potential is going to start shooting up to become rapidly more positive. It's going to go up and up all the way until it gets to about 10 millivolts, and then the next phase will begin, the repolarization phase. Actually, these voltage-gated calcium channels are going to close in about 100 to 150 milliseconds after they open automatically, which means that you might not make it all the way up to 10 millivolts. It depends on how quickly the membrane potential is changing. No matter what, after 100 to 150 milliseconds, when the voltage-gated calcium channels automatically close, the repolarization phase will begin. In the repolarization phase, the voltage-gated potassium channels open. They open at that positive membrane potential of around 10 millivolts. All right, so the calcium channels will have automatically closed after 100 to 150 seconds, and the potassium channels will open once the membrane potential gets close to 10 millivolts. At that point, you have potassium leaving the cell. That is positive charges leaving the cell, which means that the inside is becoming less positive, which is the same as more negative. So the membrane potential is going to start creeping down or moving down and repolarizing. When you get back to around negative 40 millivolts, then the minimum potential phase will begin as the HCN channels open. So during the minimum potential phase, the potassium channels are still open, so you still have potassium leaving the cell, and your HCN channels have also opened, which means you have some potassium leaving through those channels and some sodium entering through those channels. So the cell is overall having more potassium leaving than what it has sodium entering, and it's going to continue to repolarize, but it just might be moving a little bit more slowly than it had in the repolarization phase because of that sodium current as well. Once you get back down to about negative 60 millivolts, the voltage-gated potassium channels will close, the HCN channels remain open, and you begin the slow depolarization phase again. So those action potentials in the pacemakers are ultimately going to be distributed to the regular cardiomyocytes, which will have action potentials of their own and contract. Cardiomyocytes contract pretty similarly to how skeletal muscle cells contract. So we won't go through the nitty-gritty details of how that works because we went over it in AMP1 already. I'll just summarize where some of the differences from skeletal muscle contraction are for cardiomyocyte contraction. So again, you have 4 phases just like with skeletal muscle contraction, and they are excitation, contraction coupling, contraction, and relaxation. In the excitation phase, you have action potentials that are coming from the pacemakers being spread to the contractile cardiomyocytes, which are the regular cardiomyocytes. So you have action potentials entering, stimulating these contractile cardiomyocytes. So the way this phase works is a little bit different from how the excitation phase works in skeletal muscle. For one thing, your action potentials are not coming from a neuron, they're not coming from a motor neuron, they're coming from these modified cardiomyocytes. And the synapse is different. Well, you have an actual synapse between a motor neuron and a skeletal muscle cell. You don't have a synapse between a pacemaker cardiomyocyte and a contractile cardiomyocyte. Instead, you have an intercalated disc. So excitation is different for that reason. Next, you have the excitation contraction coupling phase, in which an action potential occurs in the contractile cardiomyocytes, and that causes calcium levels to increase inside the cell, which is a little bit different from how it occurs in the skeletal muscle cells, but it's mostly the same. Right, so overall, you have this action potential that is crossing the membrane of the contractile cardiomyocyte. It's going to spread down into the T-tubules and cause calcium to be released from the sarcoplasmic reticulum. The exact mechanism for how that occurs is a little bit different from how it is for skeletal muscle, but the end result is the same. Then in the contraction phase, your myofibrils are going to begin cross-bridge cycling, and that happens just exactly the same as the way it happens with skeletal muscle. Whenever calcium levels inside the cell become high enough, then the myofibrils will begin cross-bridge cycling. Actin-active sites will be revealed, it'll bind with myosin, and you'll have cross-bridge cycling occurring. Then in the relaxation phase, basically everything is resetting back to the starting position, which is pretty similar in cardiomyocytes as how it is in skeletal muscle. So you're going to have your calcium pumped back into the sarcoplasmic reticulum, and the action potential in the cardiomyocyte the last action potential in the cardiomyocyte will finish, and the membrane will repolarize back to its resting membrane potential. Of course, the relaxation phase only occurs in contractile cardiomyocytes. They are the cardiomyocytes that have a resting membrane potential. Pacemaker cardiomyocytes do not go through these phases. contract. They're just carrying action potentials, and they're constantly doing that with no rest. So now we'll cover how action potentials occur in contractile cardiomyocytes, which are the regular cardiomyocytes, not the pacemakers. These cells do have a resting membrane potential. They are not constantly cycling through action potentials, so they have a resting membrane potential, and it's about -85 millivolts. There's 4 phases to action potentials in the contractile cardiomyocytes, but the phases are different than the phases for the pacemakers, and the ion channels involved are somewhat different as well. So the contractile cardiomyocytes have 3 major ion channels that contribute to them. You have voltage-gated sodium channels, voltage-gated potassium channels, and voltage-gated calcium channels. So the first phase of the action potential in contractile cardiomyocytes is rapid depolarization, in which your voltage-gated sodium channels open and the membrane potential rapidly jumps from -85 millivolts to about 25 millivolts. So this would occur whenever the action potential from a pacemaker cell spreads to a contractile cardiomyocyte through the gap junctions at the intercalated disc. So that would mean that you have some sodium entering the cell already from that action potential in the pacemaker cardiomyocyte. So some of the sodium that has entered the pacemaker cardiomyocyte is going to spread into the contractile cardiomyocyte through the gap junctions, causing an initial depolarization that triggers this voltage-gated sodium channel to open, and then more sodium will rush into the cell. Since the sodium is moving so quickly into the cell and there's such a large amount of it, your membrane potential is going to jump up very, very steeply from the resting potential of -85 to about 25 millivolts. But that number is kind of approximate. Actually, all of the millivolt numbers for these contractile cardiomyocyte action potentials are a little bit variable, so they're all kind of estimates. The specific voltages at which things occur in contractile cardiomyocytes is going to vary from person to person. It depends on your genetics, it can depend on your age, and it can depend on what type of or what part of the heart we're talking about specifically. So the voltages can differ between one part of the heart and another part of the heart, and within one person's heart even. Right, so it's going to go up to about 25 millivolts by the end of the rapid depolarization phase. Then you're going to enter the initial repolarization phase. In that phase, your sodium channels are locked or inactivated, so their second gate, not the voltage sensitive gate, but the other gate, is closed and locked, and nothing can go through that channel in that state. Then your potassium channels are going to open really briefly. And you're going to have just a little bit of potassium leaving the cell, and the cell is going to repolarize it from about 25 millivolts to about 15 millivolts. Then you enter the plateau phase, when your voltage-gated calcium channels open at around 15 millivolts. So now you have your potassium channels still remaining open, actually even more potassium channels opening, and the calcium channels are going to open. So you have potassium leaving the cell, and at the same time you have calcium entering the cell. When potassium leaves the cell, the membrane potential becomes more negative. When calcium enters the cell, the membrane potential becomes more positive. So these two ion currents kind of cancel each other out in a way. The one is taking the cell more negative, the other is taking the cell more positive. Overall, you have more potassium leaving than what you have calcium entering. So you're going to have a slow repolarization of the cell, but it takes kind of a long time. Right, so this phase is by far the longest phase of the action potential in contractile cardiomyocytes, and you don't have a lot of change in the membrane potential for all that time. You're just going from around 15 millivolts to around 0 millivolts by the end of the plateau phase. And the plateau phase is very important for the function of the heart, as we're going to talk about just on the next slide. So after the plateau phase is over, you go into the repolarization phase. At that point, your sodium channels have reset, so their voltage gate is closed and their lock gate or their secondary gate is open. So this is now a normal closed sodium channel. Your calcium channels are also going to close, and just your potassium channels will remain open. And actually, even more potassium channels are going to open now. So you have a lot of potassium leaving the cell, and the cell is going to repolarize quite quickly back to its resting membrane potential. So the plateau phase, as I mentioned, is really important for the function of the heart. It kind of extends the length of the action potential in a regular cardiomyocyte. That allows for more time for certain things to happen. So for one thing, it allows more time for the ventricle to fill up with blood. When the ventricle is all the way full of blood, then you can have sort of the most efficient heartbeat that pumps the most amount of blood out of the heart. If the ventricles are not fully filling with blood, then that limits how much blood the heart is able to pump. So you want to make sure the ventricles have enough time to fill all the way before they actually pump. It also gives you more force for the heart contraction, especially for the ventricle. As soon as the rapid depolarization phase of the action potential has been completed, you're going to have calcium starting to enter the cytoplasm of the cardiomyocyte. And when you have this long plateau phase, the calcium is going to continue entering the cytoplasm for that whole phase. So you get more and more calcium building up in the cytoplasm, which means you're going to activate more and more myofilaments, expose more and more actin, and that means that you are going to have a much stronger contraction when more myofibrils are involved in the contraction. It also can give you more time for cross-bridge cycling to occur by just drawing out the time that it takes for the action potential to complete. And finally, it extends the refractory period. So the refractory period is the time during which you cannot fire another action potential, as you may remember from ANP1. The refractory period is partly based on the locked sodium channels or the inactivated sodium channels, and partly based on potassium channels. So in order to fire another action potential, you would need the sodium channels to open, so you could have another rapid depolarization phase. But as long as the channels are inactivated or locked, they cannot open, and they're going to remain inactivated until the voltage dips below about 0 millivolts. So as long as you're in the plateau phase, your sodium channels are going to remain locked and you cannot fire another action potential no matter what. That's important because the cardiomyocytes need to complete an action potential and they need to return to rest before they begin the next one, so that they have a period of time where they're relaxed. So if you imagine if the ventricles do not relax, then they cannot fill with blood. If they just contract and remain contracted, they're never going to be able to fill up with blood and the heart isn't going to be able to pump more blood. So if the ventricles were continuously contracted, we would call that tetanus. And the only way that could occur would be if you had action potentials firing off before the first one had finished. So in order to prevent that from happening, you have this long refractory period in the action potential for cardiomyocytes that's caused by the plateau phase. So we will talk a little bit more about excitation-contraction coupling in cardiomyocytes and exactly how that differs from skeletal muscle cells. So in your skeletal muscle cells, you have special voltage-gated calcium channels in the T-tubules that, when they are activated, open basically channels in the sarcoplasmic reticulum, where you have basically a channel that's embedded in the sarcoplasmic reticulum, but the trigger for the channel is in the T-tubule membrane. So when you open that channel, it's actually opening a path out of the sarcoplasmic reticulum for calcium to follow. In cardiomyocytes, it's a little bit different. You have an actual, you have a channel called an L-type channel in the T-tubule that lets calcium enter the cell from outside of the cell. And then once you have calcium inside the cell, calcium will bind receptors that are on the sarcoplasmic reticulum, which allows calcium to be released from the sarcoplasmic reticulum. So you have calcium entering the cell through the L-type calcium channel in the T-tubule, and then it's going to bind its receptor on the sarcoplasmic reticulum, and that causes calcium to be released from the sarcoplasmic reticulum. Then calcium is going to go and bind troponin on your thin filaments, much the same as it does in skeletal muscle cells. So you can visualize the electrical changes in the heart as it's contracting using the electrocardiogram, which is abbreviated as ECG or EKG. So the electrocardiogram is showing you electrical changes in the whole heart, or in different parts of the heart depending on where the electrodes are placed at, but it's not showing you electrical activity in individual cells. It's all the cells kind of averaged together. But the cardiomyocytes should actually be contracting in a synchronized pattern, so they should all be like pretty aligned anyways. The ECG has a characteristic pattern that it should always show, and different parts of that pattern have names, and then the distances between them also have names. So we have the three major parts of the ECG, which are the P wave, the QRS complex, and the T wave. And then you have a variety of intervals measuring the sort of distances between those features, or the time between those features. So the P wave is a short wave that appears before the major QRS complex. The P wave represents atrial depolarization. So when the atria depolarize, you get a P wave on the ECG. Next, you have the QRS complex. You have a little downturn, which is the Q, a giant spike, which is the R, and another little downturn, which is the S. All of that together is the QRS complex, and that represents ventricular depolarization, so when the ventricles are depolarizing. The atria also repolarize during this time period, but you can't see its effect on the ECG because the ventricles depolarizing is a really huge signal and it masks it. Then finally you have the T wave, which is ventricular repolarization. So when the ventricles return to their resting membrane potential, then you have the T wave. And then you have different intervals. The intervals are always including the waves on either side. So the RR interval is including the R wave. The RR interval is just from R to R. That is the time it takes for one action potential to spread across the entire heart. Then you have the PR interval that includes the P and R waves. That is the time it takes for an action potential to move from the atria to the ventricles. And that would be delayed by the AV node. So the space between the P and the R wave is created by the delaying action of the AV node as it conducts the action potential from the atria to the ventricles. Then you have the QT interval from the Q wave to the T wave, and including both those waves. That is the time it takes for an action potential to distribute across the whole ventricle. So from the beginning of depolarization to the end of repolarization is the time that the action potential is moving across the ventricles. And then lastly, you have the ST segment. The ST segment, since it's a segment, does not include the waves on either side of it. It's just the space between them. The ST segment is the time it takes for the plateau phase of the action potential to complete in the ventricles. All right, so this is your plateau phase here. During this time, the ventricles would be filling with blood, and calcium would be building up in the cardiomyocytes for a stronger contraction. You can tell a lot about someone's heart and how it's functioning by looking at the ECG and if it's looking weird. So there's several heart conditions that cause specific changes to the pattern on the ECG. In general, if you have an abnormal looking ECG, that is caused by dysrhythmia. So a dysrhythmia is just an incorrect heart rhythm, which would always be showing up on the ECG in one way or another. So first you have bradycardia, which is just slow heart rate. In order to see bradycardia, you would look at the RR interval. It's going to be longer because the heart is beating more slowly. The opposite of bradycardia is tachycardia, which is a fast heart rate. That's going to cause the RR interval to be shorter. You can also have a heart block, which is a block in the conduction system of the heart. So it basically means that one part of the conduction system isn't working and will not transmit action potentials. How that affects the ECG depends on where in the conduction system you have this block. If you have a block at the AV node itself, that's potentially very serious because it would mean that your ventricles are missing some contractions if the action potentials can't get through the AV node to the ventricles. That's going to show up on the ECG with a longer PR interval, so a longer time for the action potential to distribute from the atria to the ventricles, and you're also going to have extra P waves on the ECG. Actually, those are not extra P waves, that's the normal amount of P waves. What's really happening there is that you have missing QRS complexes. So every time that the atria contracts but the ventricles do not contract because of the AV node block, you're going to have no QRS complex on the ECG, but you will still have a P wave. You could also have a block in the right or left bundles, which would show up as a longer QRS complex as it's taking the action potential longer to distribute across the ventricles. You could also have atrial fibrillation, which means that the action potentials in the atria have become unsynchronized, so they're just kind of all over the place. That would mean that the cardiomyocytes in the atria are not contracting at the same time. Some of them would be contracting while others are relaxing. So that's going to give you a weird looking ECG where you don't see any P waves, but you can still see the QRS complex because the ventricles are still contracting normally, so you're still getting the QRS complex. In ventricular fibrillation, which is much more serious, the unsynchronized action potentials are occurring in the ventricles, which means that the cardiomyocytes in the ventricles are not contracting at the same time, and you're not going to see any identifiable pattern on the ECG at all. That is very serious because if the cardiomyocytes are not contracting at the same time in the ventricles, then you're not going to have a strong contraction in the ventricles, and the result of that would be that you're not able to pump enough blood out of the heart to supply the body. When someone is in ventricular fibrillation, you can treat that using a defibrillator, where you're basically shocking the heart. And the idea there is that you're going to resync all of the cardiomyocytes to be contracting and going through action potentials with the same timing again. So in movies and TV shows, a lot of the time you'll see that someone's ECG goes flat, they're flatlining, and then someone gets the defibrillator and shocks them, and they recover. This is not real. This does not happen. You cannot use the defibrillator to treat someone who's flatlined. You use it to treat ventricular fibrillation, not flatlining. The other thing you could see on the ECG is the flatline, which the sciencey name for that is asystole. Asystole means without systole, and systole is the part of the heart cycle where chambers are contracting. So if you have asystole, that means you have no contractions or a flat line on the ECG. That can be treated with CPR, not with a defibrillator. And there's also certain drugs that could be used to treat that as well. So here's some examples of what things can look like on the ECG, what some of these dysrhythmias look like on the ECG. Here you have tachycardia. So you see that everything is basically there. You have your P waves, your QRS complex, your T waves, but it's just faster. So if you measure the RR interval, it would be faster than normal. This diagram is an ECG with a heart block at the AV node. So you can see that you have extra P waves, like this one is an extra P wave, this one is an extra P wave, that's an extra P wave. So every time you have a P wave with no QRS complex after it, it looks like an extra P wave, but it's actually a skipped QRS complex where you didn't have the AV node distributing the action potential to the ventricles, and so the ventricles missed that contraction. So in this person's heart, the ventricles are contracting basically every other heartbeat instead of every heartbeat. Here you have atrial fibrillation. So you can see the QRS complex, but other than that, it's just kind of a random pattern. Well, not a pattern, I guess, if it's random, apart from the QRS complex. And then at the bottom, you have the ventricular fibrillation, where you don't even have a QRS complex, you just have nothing. You have a random squiggly line. So now we'll go through the steps and phases of the cardiac cycle, which basically just describes a series of events that occur in the heart with every heartbeat. So during the cardiac cycle, every chamber of the heart is going to, at one point or another, go through systole and diastole. A systole is a contraction, and diastole is a relaxation. So when the chamber is in systole, it's contracted. When the chamber is in diastole, it's relaxed. And you should have both atria going through systole and diastole at the same time, and the same thing for both ventricles. The cardiac cycle is divided into 4 phases. First, you have the ventricular filling phase, during which the ventricles fill with blood. Then you have the isovolumetric contraction phase, during which the ventricles contract. Then you have the ventricular ejection phase, during which blood leaves the ventricles and the ventricles are still contracted. And then finally, the isovolumetric relaxation phase, where the ventricles relax. And then they're still relaxed in the ventricular filling phase. So now we'll go through what happens in each of those phases. First, we need to talk about the valves, what closes and opens the valves, and the heart sounds. So the valves in the heart open and close based on pressure differences, depending on where blood is pushing on them from. So in this figure here, this is a heart that is in the ventricular filling phase of the cardiac cycle. So the ventricle is filling up with blood. Blood is spilling from the atrium into the ventricle. So when you're in this phase, there's a low pressure in the ventricle since there's not that much blood in it. In the aorta here, you have a high pressure because the aorta is full of blood. So that means that you're going to have that blood pushing up against the cusps of the aortic valve. Since they're filling the cusps, they're going to push that valve closed. So when you have low pressure in the ventricles and high pressure in the great arteries, then your SL valves will be closed. For the AV valve, the situation is the opposite. This valve is open right now. You have a lot of blood in the atrium, which means that the pressure in the atrium is high. Not a lot of blood in the ventricle means that pressure in the ventricle is low. So this pressure caused by all this blood in the atrium is going to be pushing on the AV valve. The cusps of the AV valve face into the ventricle. So when blood is pushing on it from the side of the atrium, it's actually going to push the valve open. And the valve opens and blood flows into the ventricle. In this heart, on the other hand, this is in a different phase. It's in the ventricular ejection phase of the cardiac cycle. So the pressure is kind of reversed. Now the ventricle is all full of blood, and the ventricle is also contracted, which means that there is very high pressure inside the ventricle right now. The atrium is empty, which means that the atrium has a low pressure. Actually, the atrium would probably have some blood in it. It would be filling up with blood right now, but it would have, not that much. So it's going to have a low pressure. So high pressure in the ventricles, low pressure in the atrium means that the AV valve is going to be closed. Blood is going to be pushing up on the cusps, filling the cusps of the valve up, and that's going to push the valve closed. There's actually so much pressure in the ventricle right now that the valve could be pushed open the opposite way, potentially. And that's why you have the chordae tendineae and the papillary muscle. The papillary muscles are going to be contracted, which is making sure that this valve cannot open the opposite direction. It's holding it closed in the right orientation. For the SL valve, now you still have high pressure in the aorta. You always have high pressure in the aorta, but now you have extremely high pressure in the ventricles, which means that there's more pressure in the ventricles than there is in the aorta, and the blood in the ventricles is going to be able to force the SL valve open and leave the ventricle. So for the SL valves, they're going to be closed if pressure is greater in the arteries and less in the ventricles. They're going to be open if pressure is greater in the ventricles and less in the arteries. For the AV valves, they are going to be closed if the pressure is high in the ventricles and low in the atria. They're going to be open if the pressure is high in the atria and low in the ventricles. So just make sure you are aware of when each valve would be open or closed based on what part of the cardiac cycle we are in. And you can always figure that out just by figuring out which chamber or which artery is going to have higher pressure than another. The valves are also responsible for the heart sounds, which is the lub-dub of your heartbeat that you can hear. Technically, we don't call them lub-dub, we call that S1 and S2. So the first heart sound, the lub, is S1, the second heart sound, the dub, is S2. Both of those are caused by valves closing. So the S1 sound is caused by the flaps or the cusps of the AV valve coming closed, and the S2 sound is caused by the cusps of the SL valve coming closed. So you don't get any sound when the valves open, just when they close. Okay, so now we'll go through the ventricular filling phase details. At the very beginning of the ventricular filling phase, the atria are going to be full of blood. So you have high pressure in the atria, low pressure in the ventricles, and the AV valves will be pushed open. Then blood is going to start draining into the ventricles. At first, it's just passively draining. Gravity is pulling it from the atria down into the ventricles. Then towards the end of the ventricular filling phase, you've gotten about as much blood out of the atria as is going to drain out just based on gravity. And in order to get that last bit of blood out of the atria will contract, entering systole. So at the very end of the ventricular filling phase, you have atrial systole. Once atrial systole is complete, the atria will be emptied out of blood and the ventricles will be full of blood. And at that point, you have the end diastolic volume, or the EDV. The EDV is the volume of blood that is in the ventricles at the very end of the ventricular filling phase, which is also the very end of the ventricular diastole. Right after this phase, the ventricles are going to contract. So that is basically the maximum amount of blood that you can have in the ventricles. So just remember that EDV is the maximum amount of blood that you can hold in your ventricles, or that you do hold in your ventricles in each cardiac cycle. During the ventricular filling phase, the SL valves will both be closed because you have more pressure in the great arteries than what you have in the ventricles. Next, we have the isovolumetric contraction phase, which begins when the ventricles are completely full of blood and they enter systole. So when the ventricles enter systole and contract, the pressure is going to rise in the ventricles dramatically, and it gets very high. When that happens, the AV valve is going to be pushed closed. You have more pressure in the ventricles than what you have in the atria, and actually you're going to have like a slight delay between when the AV valves close and when the SL valves open. And during that brief space of time is when you have the isovolumetric contraction phase. So the SL valves are still closed in this phase. Since the SL valves are closed and the AV valves are also closed, that means that no blood can enter or leave the ventricles. So it's all trapped there in the ventricles for now. So that's why it's called the isovolumetric contraction phase. Contraction because the ventricles are contracting, isovolumetric because they are not changing in volume. So iso means the same, so isovolumetric means same volume. As this phase is continuing, the pressure is going to increase in the ventricles as they continue to contract. Once the pressure gets high enough to open the SL valves, then the isovolumetric phase is over, or then the isovolumetric contraction phase is over. The other thing that happens during this phase is that the atria will begin filling with blood again, but they still will have like very little blood in them at this point. Oh, right, and the final thing to note is that at the beginning of this phase, when the AV valves push closed, that's when you have the S1 heart sound. So the next phase is ventricular ejection, and that begins as soon as pressure in the ventricles has risen high enough that the SL valves are pushed open. So you always have a lot of pressure in the great arteries, especially in the aorta. So the pressure in the ventricles has to be very high to get higher than the pressure in the arteries and be high enough to actually open the SL valves. When those valves open, ventricular ejection begins and blood will leave the ventricles. So the ventricles are remaining contracted for this entire phase, and blood is leaving the ventricles through the SL valves into the great arteries. At the very end of the ventricular ejection phase, you have the end systolic volume, or the ESV. That is the volume of blood that's in the ventricles after they have contracted, or at the very end of their contraction. So that is like basically the minimum amount of blood that you will have in the ventricles. The ventricles are never completely empty of blood. You can't get literally all of the blood that you filled them with back out again. So they're always going to have some blood left in there. The ESV would be that amount of blood that is left after they've ejected everything they can eject and at the very end of their systole. In the atria during this phase, they're just continuing to fill with blood. The next phase is isovolumetric relaxation. In this phase, this phase begins when the ventricles enter diastole and relax. When that happens, the pressure in the ventricles is going to drop a lot. So the pressure in the SL valves, the pressure in the great arteries is remaining high, but the pressure in the ventricles is now low, which means that the SL valves are going to close. And at that point, you get the S2 heart sound when they close. During this phase, the AV valves remain closed. The pressure in the ventricles is low, but it's not quite low enough to be less than the pressure in the atria. So the AV valves will still be closed. And it's again called the isovolumetric relaxation phase because no blood is entering or leaving the ventricles. The ventricles are relaxed and no blood is entering or leaving because all of the valves are closed at this point. By the end of this phase, the atria are full of blood. So at the beginning of this phase, they're like almost full of blood, and at the end, they're full of blood. It's a very short phase. It does not last long at all. So these graphs are showing the pressure changes in the ventricles and great arteries for each side of the heart during the cardiac cycle. On the left, you have the pressure in the right side of the heart. On the right, you have the pressure in the left side of the heart. So we'll look at the right side of the heart first. You can see in the ventricular filling phase, the pressure in the right ventricle is lower than the pressure in the pulmonary trunk. The pressure in the ventricle is rising slowly throughout this phase as the ventricle fills with blood, but it remains low because the ventricle is not contracted, it's in diastole. The pressure in the atria would be higher than the pressure in the ventricle. That line is not actually shown in this diagram, but the atria would have a higher pressure than the ventricle, which is driving the AV valve open and allowing the ventricle to fill with blood. Then you have the isovolumetric contraction phase, in which the ventricle contracts and the pressure in the ventricle rises. So first it's going to rise above the pressure in the atria, meaning that the AV valve will close, and then it's going to continue to rise, but it will not get as high as the pressure in the pulmonary trunk. Actually, it gets like at the very end of the isovolumetric contraction phase, the pressure in the ventricle equals the pressure in the pulmonary trunk, which means that the SL valve is going to be closed throughout this phase. Then at the beginning of the ventricular ejection phase, as the ventricle continues to contract, the pressure in the ventricle continues to rise, and it will pass the pressure in the pulmonary trunk, which causes the SL valve to open, and then blood is able to leave the ventricle, while the AV valve is still closed because you still have a greater pressure in the ventricle than what you have in the atria, of course. You also see the pressure in the pulmonary trunk rising during the ventricular ejection phase. That's because it's accepting the blood that is coming out of the ventricle. So all that blood that's leaving the ventricle is going into the pulmonary trunk, and that increases the pressure in the pulmonary trunk. In the ventricle itself, initially in the ventricular ejection phase, the pressure is rising as the ventricles continue to contract. But then at the end of that phase, the pressure starts to drop, and that is because you've had some blood leave. Well, you've had a lot of blood at this point, so the ventricle is still contracted, but enough blood has left the ventricle that the pressure actually drops a little bit inside the ventricle. It's still a tiny bit above or at the pressure in the pulmonary trunk. Then you have the isovolumetric relaxation phase, in which the ventricles relax and enter diastole. When they do that, the pressure in the ventricle is going to drop dramatically. So it drops below the pressure in the pulmonary trunk, which causes the SL valve to close. And it's actually still going to be a little bit higher than the pressure in the atria, which means that the AV valve will still be closed as well. At the very end of the isovolumetric contraction phase, or at the very end of the isovolumetric relaxation phase, the pressure in the ventricle is going to equal the pressure in the atria and then drop below it in the ventricular filling phase so that the AV valve opens and the ventricle can fill with blood. The same basic pattern is occurring on the left side of the heart. It's just that on the left side, everything is a bit more extreme. So you can see the max pressure on the right side is maybe around 30 millimeters of mercury. The max pressure on the left side is almost 120 millimeters of mercury. And that is because the left side is pumping blood out to the whole body, not just to the lungs. So it needs a much bigger pressure to get the blood moving over that greater distance. But the patterns in terms of where the pressure is higher in the aorta or the left ventricle, that remains constant and is the same as the pattern on the right side of the heart. So finally, we'll kind of summarize the cardiac cycle using a Wiggers diagram. The Wiggers diagram is this graph on the right side of the slide. So it's showing the ECG, it's also showing the heart sounds, and it's showing the pressure in the great artery, in the ventricle, and in the atrium. And then finally it's showing the volume of blood in the ventricles throughout the cardiac cycle. And then I also just put in this graphic showing the images of the different phases of the cardiac cycle. So starting in the ventricular filling phase, the ventricles are filling up with blood. You have a low pressure in the ventricles because they don't have much blood and they are relaxed in diastole. The atria have a higher pressure than the ventricles because the atria are full of blood. And that means that the AV valve will be open and blood is entering the ventricles from the atria. As blood enters the ventricles from the atria, the the volume of blood in the ventricles is going to rise. And at the very end, near the end of the ventricular filling phase, you have atrial systole, which shows up as the P wave on the ECG. And you can see that in response, the pressure rises in the atria, and then the pressure rises in the ventricle as well as it accepts the extra blood from the atria. At the very end of the ventricular filling phase, the volume of blood in the ventricles is at its maximum, which is the EDV, or the end diastolic volume. At that point, you enter the isovolumetric contraction phase and the ventricles contract. The volume in the ventricles stays the same because it's isovolumetric. The pressure in the ventricles goes up as the ventricles contract. First, the pressure goes higher than the pressure in the atria, which means that the AV valves will close and you get the S1 heart sound. At the end of this phase, the pressure will be almost as much as the pressure in the great artery. Basically, it'll be the same as the pressure in the great artery. So the SL valve will still be closed because throughout most of this phase, the artery has greater pressure than the ventricle, and at the very end of this phase is when that relationship shifts. On the ECG, you can see the QRS complex is almost all occurring during the isovolumetric contraction phase, as the ventricle depolarizes and then contracts. So contraction is going to follow just a tiny bit after depolarization. So the depolarization begins technically during the ventricular filling phase, but then the actual contraction of the ventricle doesn't begin until the isovolumetric contraction phase begins. As soon as the pressure in the ventricles has exceeded the pressure in the great artery, you are going to enter the ventricular ejection phase, and the SL valve is going to open. Once the SL valve is open, blood will begin leaving the ventricles and entering the great artery. You're going to see the pressure in the artery go higher as it accepts the extra blood from the ventricle. The pressure in the atria will remain much lower than the pressure in the ventricle, so the AV valve is remaining closed, and the volume of blood in the ventricle is going to start decreasing throughout this phase. At the very end of the ventricular ejection phase, the volume of blood in the ventricle is at its minimum level, and that is the ESV, or the end systolic volume. Also at the very end of this phase, the pressure in the ventricles drops below the pressure in the artery again. As soon as the pressure in the ventricle drops below the pressure in the artery, you have the SL valves close again. And then you're going to enter the isovolumetric relaxation phase. So in the isovolumetric relaxation phase, the ventricles will relax and enter diastole. Before they relax, they have to repolarize. So during the ventricular ejection phase, you actually have your T wave, which is the electrical signature of the repolarization of the ventricles. And then just after that, they're going to relax in the ventricular, the isovolumetric relaxation phase. Your pressure is going to drop in the ventricles once you're in the isovolumetric relaxation phase as they are relaxed. The SL valves are going to close when that pressure drops below the pressure in the artery. That causes your S2 heart sound, which is the closing of the AV valves. Your pressure in the atria remains much lower than the pressure in the ventricle throughout most of this phase. At the very end of the isovolumetric relaxation phase, the pressure in the atria and the ventricle are equal to each other. Then you begin the next ventricular filling phase, and the first thing that happens there is that the pressure in the ventricle drops just below the pressure in the atria, which means that the AV valve is going to open and you begin ventricular filling, and then the whole thing will repeat. So now we'll talk about cardiac output, which is the blood, how much blood the heart is pumping out, and we'll talk about how the body is controlling cardiac output. So cardiac output is defined as the volume of blood that's pumped through the heart within 1 minute. It should be the same on each side of the heart. It should be about 5 liters. It depends on your age, on your gender, and on your size. Basically, if you have more of you, then the heart needs to pump more blood to get to all of you. But the volume should be the same on each side of the heart. So on the left side, you need a much greater pressure, a much greater force to drive the blood over a much greater distance. But on the right side, even though you need less force, you need to move the same amount of blood. It's just easier to move it because the distance that you're moving it is smaller. But if you actually had one side of the heart pumping a different volume than the other side of the heart, then that would lead to a backup somewhere in the system, and that would be a problem. So each side needs to pump the same amount of volume, even though for one side it's easier and for the other side it's harder. You have a formula to calculate cardiac output, which is abbreviated as CO. The formula is cardiac output equals heart rate times stroke volume. So the heart rate, or HR, is how many times the heart beats every minute, or how many cardiac cycles the heart completes in every minute. The stroke volume, abbreviated SV, is the volume of blood that is pumped through the heart in each heartbeat or during each cardiac cycle. So the stroke volume itself has another equation, which is stroke volume equals EDV minus ESV. So that just means that the stroke volume equals the maximum volume in the heart minus the minimum volume in the heart. And when I say heart, I actually mean ventricles, because the blood that's in the ventricles is the blood that's being pumped out of the heart. So something to note here is that we usually measure cardiac output in liters, but when we measure stroke volume, we usually measure it in milliliters. So if you have your stroke volume in milliliters, you have to convert it to liters before you can use the cardiac output equation. Or you have to convert your answer from milliliters to liters. So just take note of that in your future nursing classes. So in general, this equation means that when the heart beats faster, cardiac output goes up, and it means that when each heartbeat pumps more blood, the cardiac output goes up. But there is a limit to that for the heart rate. If your heart rate is extremely high, the cardiac output will actually go down, not up. Because if your heart rate is too high, then you don't have enough time for the ventricles to fill with blood before they're contracting. So if the ventricles aren't able to fill all the way, and then you're contracting again, and then again they're not able to fill all the way, and you contract again, that means that stroke volume is going to tank, and cardiac output as a whole will go down. So your heart rate can go up to increase cardiac output, but only to such a point, and after that, having a higher heart rate actually hurts your cardiac output. So in order to measure cardiac output, we need to know the stroke volume, but it's really hard to measure the stroke volume without getting all up in someone's heart, which is not something that you want to do to them. So we use something called the ejection fraction instead. The ejection fraction is the percentage of blood that's ejected from the ventricles during systole. It's not the same as stroke volume, but it's very close to stroke volume, and it's a good way to estimate stroke volume. You can measure ejection fraction using an echocardiogram. This image here is an echocardiogram of the heart showing the ventricle. So you would basically measure the amount of area that is taken up by this ventricle. The dark spot is the ventricle. And you can watch the heart beating. As the heart beats, the space is going to get bigger and smaller as the ventricles contract and relax. So you would basically measure how big are they when they're relaxed versus how big are they when they're contracted, and that percentage is the ejection fraction. It's actually a little bit hard to do it. The computer program is going to measure the area in here for you, but you still have to draw the space for it. So you have to draw where the ventricle begins and ends, and it's kind of difficult at times to tell exactly where that is. Well, it's always going to be an estimate, right? You're never going to do it like perfectly right. But for instance, this streak here, that's a papillary muscle. So the person who's doing it has to know that this streak is a papillary muscle. It's not the wall of the ventricle in order to get it right. In general, your ejection fraction should be between 50 and 65%, meaning that about half of the blood, or a little bit more than half of the blood that's in the ventricles is going to be moved out. You can also calculate, well, I guess once you have your ejection fraction, then you can calculate the stroke volume using the equation ejection fraction equals stroke volume divided by end diastolic volume, which you would get by looking at this as well. So in order to talk about how cardiac output is regulated, we need to talk about what determines the things that determine cardiac output. One of those things is stroke volume. Stroke volume has three major determinants, which are preload, afterload, and contractility. Preload is the stretch in the ventricles that's caused by blood filling them. Afterload is the force the ventricles have to overcome to push the blood out of the heart. And contractility is the force with which the ventricles contract. So preload technically is the stretch in the walls of the ventricles, but that stretch is caused by the blood that's filling the ventricles. So a lot of the time we think about preload as just being the volume of blood in the ventricles before they contract. It's the preload because it's how much load of blood the ventricles have before they contract. The main determinant of preload is venous return. Venous return is how much blood is coming back to the heart in the veins. So if you have, X amount of blood coming back to the atria from the vena cava, that blood is going to go into the ventricles, and that's your preload. You can't pump more blood out of the ventricles than what you had filled them with initially. So preload is determined by venous return for the most part. Then you have afterload, which is the force the heart must overcome in order to force blood out of the ventricle and into a great artery. That is determined in most part by the vascular resistance or the arterial blood pressure. It's a little bit weird. It's kind of determined by like both. Vascular resistance, we're actually going to talk about it in a moment, but vascular resistance is the resistance of the blood vessels to the flow of blood through them. So the more that the blood vessels resist blood going through them, the greater the vascular resistance they have. And the more resistance there is, the harder it is to pump blood through those vessels, which means that the afterload goes up. Then finally, contractility is more simple. That's just the force with which the ventricles are contracting, how much force they generate when they contract. So that can be increased by the sympathetic nervous system. It's mostly constant, but the sympathetic nervous system is actually able to make it go up. So looking more at preload, that technically is mostly determined by the EDV, the end diastolic volume, which means the stretch in the walls of the ventricles caused by blood is determined by how much blood is in those ventricles just before they contract, and that is the EDV. The EDV is determined by how much blood entered the ventricles during ventricular filling, which came from the atria, and then how much blood you have in the atria is determined by venous return, which is how much blood is going back to the heart from the body. Specifically, venous return is referring to the right atrium, but since the two sides of the heart should be synchronized, it should be the same for the left atrium as well. The other thing that can determine the end diastolic volume is just the time spent in ventricular diastole. So how much time the ventricles are relaxed. If they are relaxed for a longer time, you can fill them with more blood up to a point. This mostly comes into play if you have a fast heart rate, though. If you have a fast heart rate, then the ventricles are spending less time in diastole, which means that they are not able to fill with as much blood because there's just not as much time. There's not as much time for them to do it. They can only fill when they're relaxed. So if they're not filling with as much blood, then your preload is going to go down. Cardiac output gets pretty complicated because a lot of the factors that affect it are also themselves affected by cardiac output, and venous return is a good example. So venous return is going to go up anytime that cardiac output goes up, right? The more blood goes out of the heart, the more blood goes back to the heart. So if cardiac output goes up, that means that venous return goes up, but if venous return goes up, that also means that preload goes up, and if preload goes up, cardiac output also goes up. So it's a little bit that's a little bit of a positive feedback loop there. Another thing to be aware of is the Frank-Starling law, which just states that more stretch in the ventricular cardiomyocytes means more contractility. So basically, the bigger the preload is, that means more stretch in the ventricles, and when they are more stretched, they generate more force when they contract. So having a higher preload also affects contractility by increasing it. We're not sure exactly why that occurs, but it's possible that the myofibrils, when the preload goes up, are kind of stretched apart from each other, which means that they have more space to interlock during cross-bridge cycling. And it's also possible that more calcium is released when the heart is stretched more. Stroke volume is also determined by afterload, which is the force that opposes the flow of blood out of the heart. Afterload itself is mainly determined by vascular resistance and arterial blood pressure. So vascular resistance is the resistance of the blood vessels to the flow of blood through them, and it's different for each circuit. So the systemic blood vessels have a much higher resistance than the pulmonary circuit vessels have. That's just because the systemic vessels go for longer. So the greater the distance that blood has to travel through a blood vessel, the greater the resistance to its flow is going to be. So just because the systemic blood vessels are longer than the pulmonary blood vessels, that means that vascular resistance is much higher in the systemic circuit than in the pulmonary circuit. You may hear a term systemic vascular resistance, or SVR. That means specifically vascular resistance in the systemic circuit. And that's also called total peripheral resistance, or TPR. So that's the same thing. This just means vascular resistance in the systemic circuit. We usually don't talk about vascular resistance in the pulmonary circuit. Not that it doesn't matter. It's just that resistance is much higher in the systemic circuit, so that's the one that we usually talk about. But SVR and TPR are both terms that mean specifically resistance in the systemic circuit and not the pulmonary circuit. Vascular resistance is determined by vasoconstriction or dilation, which would mean the diameter of the blood vessels. Vasoconstriction would mean vessels that have a smaller diameter because they're contracted. Vasodilation means a larger vessel because its walls are relaxed. It's also determined by blood viscosity, which is how thick the blood is, and by vessel compliance, which is how stiff the blood vessel walls are. And just to note that arterioles are the biggest contributors to vascular resistance out of all these systemic vessels. Arterioles are the tiniest arteries. They're the biggest contributors because there's a lot of them and they have a very small diameter. So vascular resistance is going to go up if your vessels are smaller, if they're vasoconstricted. Resistance also goes up if the blood is thicker, so there's more viscosity. But vascular resistance goes down if the vessels are more compliant. So if the vessels are more compliant, that means that their walls are not as stiff. If the walls are not as stiff, then when you add more blood, the vessel can bulge to accommodate the extra blood, and that reduces the vascular resistance. Right, so vascular resistance goes up with vasoconstriction and with blood viscosity, but it goes down with vessel compliance. When vascular resistance is high, afterload is going to be high, and the higher the afterload is, the harder it is for the heart to pump blood into those vessels, which means that the cardiac output will go down. Vascular resistance is not the only thing that affects afterload, though. You also have to take into account the arterial blood pressure, because the blood pressure is also affected by the blood volume. So blood volume just means how much blood you have in the body. The more volume of blood you have, the more blood pressure you're going to have, and the more resistance there's going to be to pumping blood into these vessels that are already very full of blood. So when you have a higher blood volume, you have a higher blood pressure and a higher afterload and a lower cardiac output. Vascular resistance does not account for blood volume, which is the reason why you have to take into account blood pressure as well when you're determining what the afterload is, or if it's high or low. Blood pressure itself, though, is also determined by the vascular resistance and by the cardiac output and by the blood volume. So it's kind of tricky. If vascular resistance goes up, blood pressure is going to go up. If blood pressure goes up, vascular resistance will go up. All of these things are increasing afterload, but then afterload, if that goes up, that decreases cardiac output, and if cardiac output goes down, then blood pressure goes down. So it's a really complicated system, actually. Cardiac output is regulated by the nervous system and by the endocrine system. The nervous system regulates it using the sympathetic nervous system and the parasympathetic nervous system. So you have both the SNS and the PNS sending axons to the SA node so they can control heart rate. Then the SNS also sends axons to the whole body of the heart, especially the ventricles, and it controls contractility as well. So when your SNS is activated, or when your sympathetic nervous system is activated, your heart rate will go up and the contractility will go up, and that means that stroke volume goes up and cardiac output goes up. If your PNS, if your parasympathetic nervous system is activated, it's the opposite effect. The heart rate will go down. Contractility will actually not be affected, but heart rate will go down. When heart rate goes down, cardiac output will go down. So the SNS increases cardiac output and the PNS decreases cardiac output. Of course, the SNS also has effects on vasoconstriction. When the SNS causes vasoconstriction, that means that vascular resistance goes up, and then that increases afterload, which decreases cardiac output. So the effects of the SNS that increase cardiac output are also somewhat offset by the effects that decrease cardiac output by increasing vasoconstriction. And here we have a couple of vocab words for drugs: inotropic agent and chronotropic agent. An inotropic agent alters the contractility of the heart. So SNS neurotransmitters are inotropic agents by altering the contractility. A chronotropic agent is something that alters the heart rate, chrono meaning time. So the neurotransmitters of the SNS and of the PNS are both counting as chronotropic agents since they affect the heart rate. Also, drugs that people may take for heart conditions are frequently going to be classed as chronotropic agents or as inotropic agents, depending on how they're affecting the heart. The endocrine system also regulates cardiac output. You have a bunch of different pieces of the endocrine system that affect cardiac output. First, you have just the adrenal medulla, which is going to release adrenaline or epinephrine anytime the SNS is activated. And that hormone, epinephrine, has the same effects on the heart as the SNS system does. Then you have the RAAS, which we're going to talk more about when we cover the kidneys. But the RAAS stands for renin, angiotensin, aldosterone system. It's a system of related hormones that all participate together, mostly to control how much water you have or in your body, how much urine you're making. And they also can affect vasoconstriction. So two of the hormones that are part of that system are angiotensin II and aldosterone. Angiotensin II causes vasoconstriction. Vasoconstriction is going to increase vascular resistance, which increases afterload, which decreases cardiac output. Angiotensin II also causes the release of aldosterone, which is a hormone that increases water retention by the kidneys. When water retention is up, that means that blood volume goes up. That means that blood pressure goes up. That means that afterload goes up. That means that cardiac output goes down. So in general, the RAAS is going to decrease cardiac output by causing vasoconstriction and water retention that increases blood volume and blood pressure. The graphic here is showing the RAAS. We don't have to worry about this in detail until we cover the kidneys, but essentially the kidneys are releasing the hormone renin, which through several different steps ultimately activates the hormone angiotensin II. The hormone angiotensin II causes aldosterone to be released and causes vasoconstriction. Then aldosterone causes water retention in the kidneys. And all in all, the system is increasing your blood pressure, increasing the blood volume and the blood pressure. So it would be activated anytime your blood pressure is low. Another hormone that affects cardiac output is ADH, or antidiuretic hormone. That also causes water retention in the kidneys. Therefore, it increases blood volume, so it increases blood pressure, increases afterload, and therefore decreases cardiac output. Next, you have AMP and BNP, which are both hormones released by the heart. Those hormones do the opposite thing. They decrease water retention in the kidneys, which means they increase the production of urine. When you're increasing the production of urine, blood volume is going to go down, blood pressure goes down, afterload goes down, and therefore cardiac output would go up. So finally, we'll talk about a common heart condition, heart failure, which is the inability of the heart to pump sufficient blood to supply the body with oxygen. So generally in heart failure, what's going wrong is that the stroke volume isn't high enough. So the ventricles are just pumping a small amount of blood with every cardiac cycle. Usually that's because they're not contracting with enough force, so they have reduced contractility. Heart failure has a lot of different causes. Anything that leaves the heart in a weakened state can be a cause of heart failure. So that could include a heart attack, could include a heart infection, or anything that leaves the heart weakened. It could also be a problem with ions. If you don't have the right concentrations of sodium, potassium, and calcium inside and outside the heart cells, then you're not going to be able to have action potentials occurring properly in the heart cells, which means you won't have contractions occurring properly either. There's multiple types of heart failure. So heart failure could affect the left side or the right side of the heart, and it could be systolic or diastolic. Left-sided systolic heart failure is the most common type of heart failure. So usually if you hear heart failure, people are talking about left-sided systolic heart failure. Left-sided heart failure is where the left side of the heart has been weakened. Right-sided heart failure is where the right side of the heart has been weakened. It could also be on both sides too. Sometimes if you have left-sided heart failure, as the disease progresses, you may end up with right-sided heart failure as well. In systolic heart failure, the problem is occurring during systole, and the problem is basically that the ventricles are not contracting with enough force, so they have reduced contractility. In diastolic heart failure, it's different. Instead of the ventricles not contracting properly, they're not able to fill up with blood properly during diastole. In general, that would be because the walls of the ventricles have become too stiff and they can't expand to accommodate blood. If you have left-sided heart failure, a common symptom or result of that is pulmonary edema, which is swelling in the lungs. So what's happening is that blood is coming into the heart from the lungs on the left side, and then the left ventricle is going to pump it out to the body. But if the left ventricle isn't pumping enough blood out, that means you have too much blood left behind, and blood is going to start getting backed up. It's going to back up into the left atrium, then it backs up into the pulmonary veins, and ultimately it will back up into the lungs, and you will get fluid leaving the blood vessels in the lungs and entering the lung tissue. So you can end up with swelling of the tissue and fluid in the lungs, which can also interfere with breathing and cause shortness of breath. With either type of heart failure, you can also end up with swelling throughout the body, but usually in the legs and the lower part of the body. That would also be because blood is backing up and is spilling out, is being kind of pushed out. Fluid is being pushed out from the vessels, causing the swelling. The body's response to the failing heart actually makes the condition worse and accelerates the progression of the disease. So anytime that the body senses that there's not enough blood being supplied to the organs, it will respond by trying to increase cardiac output. And the body has a couple ways to do that, but the most immediate way would just be to increase the heart rate. So anytime heart rate goes up, that means that the heart's oxygen demands go up, which means that the heart would need to pump more blood to supply itself with enough oxygen to meet that increased demand. But this is already a weak heart that wasn't pumping enough blood to start with at rest. So that means that now the heart is having an even harder time meeting its needs and has an even greater oxygen deficit and may well sustain additional damage. Another thing the body does in response to reduced cardiac output is to start releasing hormones like angiotensin II and aldosterone and ADH. The ultimate effect of these hormones is to increase water retention in the kidneys. That increases blood volume, and when you increase blood volume, you increase blood pressure, which in general increases the flow of blood around the body. But in this case, it's just overloading the heart further. You already were having blood getting backed up into the vessels because the heart wasn't able to pump enough. And so now that backup is just going to get worse. Another thing that occurs in the response to heart failure is cardiac remodeling. Cardiac remodeling occurs, in a lot of different contexts actually. So if you're exercising a lot, then you're going to have cardiac remodeling also. So it doesn't have to be a bad thing. It could be a good or a bad thing. Depends on what type of remodeling is happening. The remodeling just means that the structure of the heart is changing. In remodeling that occurs in response to heart failure, the ventricles end up getting bigger. And the way that happens is that the walls of the ventricles thin out to make more space inside the ventricle for blood. So that is not a good thing because when the walls are thinner, they are weaker. And so now the contractility of the heart goes down even further. So when we first started trying to treat heart failure, we followed basically the same strategy that the body follows. If your heart isn't pumping enough blood, well, speed it up. So we would give drugs that would increase heart rate. And we would find that the people get better at first. At first, their symptoms are not so bad. They have an easier time like walking around and maybe even exercising. They don't get out of breath and winded so quickly for a little bit. and then they decline more quickly than they would have otherwise, and they die faster than a person who wasn't treated at all. And so now we have realized that in order to properly treat heart failure, you have to do the opposite thing. Instead of speeding the heart up, you have to slow it down. You have to slow the heart rate down and prevent it from increasing, so that the heart will never have too high oxygen demands that it can't meet, or at least the heart will be able to meet its oxygen demands better for longer. So you'll give drugs that limit the heart rate, basically like beta blockers, that prevent the sympathetic nervous system from telling the heart to speed up. You can also do exercise for heart failure. You have to be very careful because anytime you're exercising, heart rate goes up, the heart's oxygen demands go up, so that can be dangerous. So you have to do, light exercise, but it actually does help strengthen the heart and build it back up, and it can greatly increase your lifespan and quality of life. If you start treating heart failure soon enough, actually, you can even recover from it. It is possible in many cases to restore the functionality of the heart back to normal. So you would definitely need to talk to your doctor about an exercise plan that would work for you and not be too much strain for your heart. Another important part of lifestyle changes to treat heart failure is limiting salt intake, and in some cases even water intake. When you take in a lot of salt, that means that the kidneys will end up retaining water in order to balance out the extra salt in your body. And so that creates an extra load for the heart and extra problems for the heart. So you limit your salt intake to reduce your blood volume to a more manageable level for the heart. If you're having really bad edema in the lungs, a lot of fluid building up in the lungs, then you will end up in a state where you have to actually limit how much water you drink in a day. Because if you have too much fluid in your lungs, then you won't be able to breathe. So it's a really pernicious condition that develops over years and is very difficult to treat, but it is possible to treat it with the right medications and extensive lifestyle changes.